Hi guys, so this is the Chapter 6 key points video for OT101. Chapter 6 covers the integumentary system, which is your hair, skin, and nails. Alright, so we start with talking about the skin's functions. The skin is one of the largest organs. It protects the body from trauma, from infections, and from toxic chemicals. It includes accessory organs like the hair and the nails and some other glands we got mixed in there too. Within the skin are millions of tiny nerve endings, and these are called receptors. These receptors sense touch, they sense pressure, pain, and temperature. If you're alive, you've probably already figured that out. The skin has roles in protection, sensation, and the synthesis of vitamin D. When the skin's exposed to sunlight, the skin synthesizes vitamin D. So we actually need sunlight to synthesize this vitamin D and to regulate some of our other body processes. The skin also, lastly here, assists in the regulation of body temperature and excretion. So imagine how cold we would be if we had no skin protecting us. It would be pretty miserable. Dermatitis is the inflammation of skin. There are a couple of different types that you should be aware of. There's seborrheic dermatitis, which is one of the most common skin disorders. It's an inflammatory condition of the sebaceous or oil-producing glands. The affected skin is going to look reddened. It's going to be covered by these yellowish, greasy appearing scales, and that greasy appearance comes from the fact that it affects the sebaceous glands. Contact dermatitis is an acute inflammation response of the skin, which is triggered by an exogenous chemical or substance. So something from outside of the body has triggered a response from the skin and caused it to become inflamed. Symptoms include erythema, edema, and small vesicles that ooze, itch, burn, or sting. Atopic dermatitis is also more commonly known as eczema. It is a chronic inflammation of the skin that tends to occur in patients with a family history of allergic conditions. The eczema rash will occur in a characteristic pattern on the face, neck, elbows, knees, and upper trunk of the body, and it's typically accompanied by pruritus. Psoriasis is a chronic condition marked by thick, flaky, red patches of various sizes, so they can be all different kinds of shapes and sizes, but they're all pretty consistently thick and flaky and have this red around them or on them, and they're covered with characteristic white silvery scales. They usually do not cause discomfort, but they may be slightly itchy or kind of sore or tender. The affected skin typically appears dry, cracked, and kind of crusty or encrusted. The cause for psoriasis is unknown, but it seems to be genetically determined. Psoriasis may also be part of an autoimmune disorder, so just kind of keep that in mind. Acne vulgaris is an inflammatory disease of the sebaceous glands, or those oil-producing glands, and the hair follicles. It's marked by the appearance of papules, pustules, and comedones, which are basically zits and blackheads. Also, deeper boil-like lesions called nodules can sometimes occur. It's found most often on the face, but can also occur on the neck, shoulders, chest, and back. And so sometimes you'll hear people refer to it as chest knee or back knee. And so you sometimes, I'm sure, have seen at some point somebody with pretty severe acne, and you know that they've got these flare-ups, and they can be pretty intense and pretty painful. The cause of acne vulgaris is unknown. However, in girls, it's usually at its worst between the ages of 14 and 17, and in boys, it reaches its peak in the late teens. And so that is pretty typical of pubescent ages. So a lot of times kids will end up going on some type of, if you're take your child to the dermatologist, they'll end up going on some type of acne regimen. My youngest son had acne pretty badly. It hit him when he was about 12, and when he was 13, we took him to the dermatologist, and because I was worried about the scarring that it was causing, and he ended up going on through this whole Accutane regimen, which is like a huge FDA issue. So there are treatments for them, but they are very heavily regulated. Some of the more effective treatments are very heavily regulated. Accutane was taken off the market for a while and is now very, very heavily regulated because it causes severe birth defects. It causes anencephaly. And so you have to sign all kinds of disclaimers, and you have to register with the, there's like a whole FDA monitoring program you have to register with, and all kinds of fun stuff. So for him, him getting pregnant was not a big deal, and I didn't really have a whole lot of concern for him getting anybody pregnant at 12. So we were able to go through with this treatment, and it cleared his face up wonderfully, but it does do some damage to the liver. Thankfully, he came out of it pretty okay, but we had to go have blood draws done every month on like clockwork. They won't give you the next month's prescription without blood draws or anything. So there's all kinds of things that can be done to help treat acne, but a lot of it can be pretty involved and can be costly if your health insurance doesn't cover it. Okay, the next one is herpes zoster. Herpes zoster, or it's more commonly known as shingles, is an acute inflammatory dermatomal eruption of extremely, extremely painful vesicles. The incubation period for herpes zoster or for shingles is from about 7 to 21 days. The duration of the disease from the time of onset to the time of recovery is usually 10 days to 5 weeks. 5 weeks is a long time to be in that much pain. The pain begins about 2 to 3 days before the appearance of the lesions, and the eruption will begin as a rash, and then it rapidly develops into the vesicles. So the skin that overlies the affected dermatome or dermatomes becomes reddened, and then it blisters. Patients who experience the onset of herpes zoster often experience this excruciating pain in the affected area. I mean, like it's difficult to sit down, it's difficult to lie down, showering is excruciating. I mean, it's very, very, very painful from what I understand to have shingles. The cause is the herpes varicella zoster virus. This also happens to be the virus that causes chickenpox. So that's why if you've had the chickenpox virus as a child, you are at a much more substantial risk to develop shingles as an adult. For unknown reasons, this virus will lie dormant for years in the dorsal root ganglia, and then all of a sudden it wakes up and it's like, hey, I'm going to go make somebody's life hell today. And then it does. It makes somebody's life hell for 2 to 3, 5 weeks, So there's no explanation, no rhyme or reason. It's just if you've had this virus, it's dormant somewhere in your body, and then it wakes up and it's like, today's the day. And then it just kind of goes to town. So the good news is, for everybody who is watching and listening, the good news is there is now a shingles vaccination, and if you are concerned about developing shingles, then it is a fantastic idea for you to get the shingles vaccination, because taking the little pain of the shingles the vaccination injection is infinitely better than spending 5 weeks unable to sit or lie down or shower or drive or anything without feeling like somebody is slicing your skin open nonstop. So there's my promo for the shingles vaccination. Go get it if you need it. And if it's not you, tell your parents. Old people are like crazy prone to getting shingles. And so tell your parents, go get the shingles vaccination. They will thank you later when they do not have shingles. All right. Oh, by the way, shingles? Crazy contagious. Okay, so cellulitis is an acute diffuse bacterial infection of the skin and subcutaneous tissue. Erythema and pitting edema develop with cellulitis, and the skin becomes tender and it becomes hot to the touch. Like you can feel it and you know that there's an infection brewing under there because it's literally much warmer. You can almost feel like a fever in that one spot. It's like a centralized or a localized fever where this infection is underneath the skin. Red lines or streaks may appear proximal to the infection and run along lymph vessels. If you see red lines or streaks, that is a good time to take somebody to the urgent care, get them to the doctor, get them seen immediately, because cellulitis unfortunately can very quickly develop into sepsis if left untreated. Cellulitis is easily treatable with antibiotics. However, if it's untreated, then it can turn into sepsis. And when you become septic, you have all kinds of problems you really do not want to have. Sepsis is infection in the bloodstream, and your blood goes through all of the tissues in your body, and so that's bad news bears right there. The cause for cellulitis is either streptococcus or staphylococcus that enters skin via a small cut or lesion. So what happens is there's a bacteria that gets in there, and then it settles down in to the skin and the subcutaneous tissue, and then that all gets infected, and then it gets hot, and you get sick, and it's swollen, and it's red, and it's yuck. So definitely need antibiotics to clear that up. Cellulitis is not something you want to mess with, because that can cause a whole lot of problems for you later on if left untreated. Okay, so decubitus ulcers are commonly called bed sores or pressure ulcers. It's a localized area of dead skin that can affect the epidermis, which is the upper layer, the dermis, which is the middle layer, and the subcutaneous, which is the fatty underlayer of the skin. An early sign of a decubitus ulcer is a shiny reddened skin appearing over a bony prominence in individuals with prolonged immobilization. Okay, here's my thing, and this is my little bone to pick with all of you who are going to be working in healthcare. If you're watching this and you are a student of mine, then you are going to be working in healthcare at some point. That's your end game. There is no reason for people to have decubitus ulcers. These are bed sores, and you get bed sores from being neglected. People have, if they are immobile and they are unable to turn themselves, then the aides or the nurses or us, as whoever it is, the caregivers, are to turn them to prevent these pressure sores or bed sores, decubitus ulcers, from developing. Okay, I once saw a patient come into the emergency room where I worked, and she had a decubitus ulcer the size of an 8-inch dinner plate with maggots. And that was because she was left, even though her children lived out of state from where we were, and they hired a home health aide for her through a visiting nurse service. They had hired a 24/7 aide for her, and the aide was getting paid but forgot to do her job, and so she just never really properly bathed or changed or turned this patient who was immobile. She had had a stroke, and she had lost function of her limbs. She couldn't do it herself. And so this patient basically, when she came in, had maggots to her bone because she had been left unturned in soiled conditions for a couple of months. So they can get pretty bad pretty quickly, and there is no other way that I can fathom for a patient to present with this type of ulcer other than some type of neglectful situation happening. So kind of keep that in mind. So other signs of these bed sores include blisters, erosions, necrosis, which is dead tissue, which is black. You'll see that. Oh man, this lady with the bed sore, the big bed sore, black all the way around it. And that's what the maggots were doing. Actually, as disgusting as the maggots were doing her a favor by eating all of that necrotic dead tissue and keeping the wound somewhat healthier, as crazy as that sounds. And then ulceration also. It's caused by impairment or lack of blood supply. So again, if you have good caretakers that are taking care of your loved ones, and they are moving them and flipping them, and they're not left immobile for very long, then these should not be an issue. Parasitic infections. It's going to make everybody itch. You have itch mites, which are scabies, and then lice, which is pediculosis. Those are the two main parasitic infections that are known to infest humans. There are 3 types of lice that you should be aware of. There's the head louse, The scientific name is Pediculus humanus capitis, and the body louse, which is Pithyrus humanus corporus, and then the pubic or crab louse, which is Pithyrus pubis. Those are all of the different types of lice that you should be aware of. These all produce an intense pruritus or itching, and then a sensation of something crawling on the skin. So you get like the creepy crawlies, kind of like when a spider is crawling on you. Or if you are a person who has long hair, if you've ever had like a stray hair crawl down your back, or fall off and go down your back, and you feel like something's crawling on you, it's kind of like that. So scabies is a rash that is accompanied by intense itching. Lice can produce a rash or wheals, but the most common sign or symptom is the presence of nits on hair shafts and skin and clothing. So both of these are spread easily by close physical contact. So both scabies and lice are very, very contagious. They are both of them contain or consist of a very lengthy, labor-intensive process to contain them and to eradicate them. And so if you know somebody has a known scabies or lice infestation, you want to do your best to either steer clear or protect yourself from also contracting these very, very contagious infections. Okay, so pre-malignant tumors are non-cancerous growths or tumors on the skin, and they fall into two categories. There's benign and then there's pre-malignant. So benign means non-cancerous altogether. Pre-malignant means that it's precancerous. So benign tumors are usually a cosmetic problem only, and those are things like skin tags and moles that are not pre-malignant and warts that are not pre-malignant, those types of things. You have some lesions, and there's all kinds of them listed in your textbook. I did not put them in here, but you can read through all of those. And so, they're pretty much just kind of like keloids are typically benign, and so they're ugly, but they're not really anything to be concerned with medically. Pre-malignant tumors, on the other hand, must be identified and treated as early as possible to prevent them from developing into malignancies. So actinic keratoses are common pre-malignant lesions, and they are seen on sun-exposed areas of the body. It's caused by long-term exposure to the UV portion of sunlight, and their numbers will increase with a person's age. So that makes sense, because the older you are, the longer you've been exposed to the sun, right? I mean, like a 2-year-old can't possibly have spent the amount of time in the sun that a 75-year-old has. So it makes sense that the number is going to increase with age. It will initially appear as an area of rough, vascular skin, and then it'll later form a yellowish-brown, adherent kind of crust-looking thing on it. So if you see any of those, there's pictures in your textbook. You can Google it also. But if you see any of those, you want to get those checked out, or recommend that your patients have those checked out. Skin cancer. This is always the bummer. So let me get this all in here there. So skin cancer is collectively the skin cancers, basal cell carcinoma, and SCC, which is squamous cell carcinoma, and malignant melanomas represent the most common type of malignancy. So because BCC and SCC usually do not metastasize, however, they often are not included on the most of the cancer registries that you'll see. So basal cell carcinoma, skin lesions, appearances. Here's a couple of things to look for those. There are shiny bumps or nodules that is pearly white, pink, red, or translucent. Listen to that. Translucent. It could have a sore that bleeds, heals, and then recurs. So it may start off as a sore that bleeds, and then it heals up, and then the sore comes back, or the sore busts open again. So that's something to watch. Smooth growth with an indented center and an elevated rolled edge or border. For squamous cell carcinoma lesions, they often present as a crusted or scaly area with a red inflamed base. Malignant melanoma is the most serious of the three types of skin cancer, but it's not as common, thankfully. It arises in epidermal melanocytes. Those are the cells that make the brown pigment melanin. It most often occurs as a solitary lesion. Changes of indication to be aware of are changes in size, color, and shape. Also watch for changes in the elevation or surface, and then a change in the surrounding skin as well. So the next slide, I think, is the A, B, C, D, E's of melanoma. So these are the things to look for. A is asymmetry, which is a lack of equality in the diameter. So if one side's bigger than the other, so if you're looking at a mole or a lesion of some sort and it's not symmetrical, then that would be something to keep an eye on. Just watch it. If it starts off symmetrical and then it becomes non-symmetrical or asymmetrical, then you want to pay close attention to that and get it checked out. Border, if the border of the lesion is notched, scalloped, or indistinct, then you want to get that checked out. Color, if it's uneven, variegated, ranging from tan, brown, black, red, white, any of those things, you want to have that looked at. The diameter, melanomas are usually larger than 6 millimeters, so you want to have that checked out. And then evolving, so it's constantly changing. So any change in size, shape, color, elevation, or any of the other traits, or any new symptoms such as bleeding, itching, crusting, or anything like that around a questionable lesion points to danger and definitely warrants getting that checked out immediately. Okay, so what do you do to prevent those skin cancers and melanomas? You protect your skin from the sun. You want to avoid the sunlight between 10 a.m. and 3 p.m. Those are when the UV rays are the strongest. I just want to make a little sidebar here. When my son started seeing the dermatologist for his acne, I also started seeing the dermatologist because I had acne when I was younger, and I have sunspot. I have like brown dark spots now, and I want to get rid of those. I'm old, and I want my face to be pretty finally, and so or my skin to be pretty, and so I went to ask her about those, and she told me, oddly enough, that I put sunscreen on. But on days when I don't plan on being outside a whole lot, I don't put sunscreen on my face. And she told me that most sunscreen exposure happens while we are driving our cars. Isn't that crazy? I never even thought of that. But here in California, where it's crazy sunny, the sun just blares through that windshield and just radiates onto your face. And so you get all kinds of sun exposure. And for those of you who are much like me and you're on the freeway all the time, especially in traffic, you're sitting there in your car with your face and your arms exposed to the sun for, hours every week. And if you're not wearing sunscreen, then that puts you at that much greater of a risk. So I had no idea. So I thought I'd pass that along to you guys too. If you plan outdoor activities for early morning or late afternoon, then you are better suited to miss those stronger UV rays. You want to wear protective clothing, especially a hat. Use sunscreen with a sun protection factor of at least 15. I will tell you another side note here. Our dermatologist told me at least 50, but she's a dermatologist, so I would expect her to be a little excessive on the sun protection. And then apply sunscreen 15 to 30 minutes before exposure, and then again after getting wet, especially after you have been swimming. So some good sun protection tips there for you. And that is going to do it for Chapter 6 for the Integumentary system. If you have any questions, please feel free to email me, message me through Canvas, and I will do my best to answer them. Thanks, guys.